So it's sharp 11:30. With audio due permission, can we begin?
Yeah, we can.
Thank you so much, sir. Good morning, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. He is none other than a very renowned endocrinologist, Dr. Anirban Sinha, sir. Sir is MBBS, MD, DM in endocrinology, FACE from USA, Associate Professor at Endocrinology Medical College, Kolkata. With the help of sir, we'll be taking a close look on today's topic, which is recent updates on immunotherapy to delay type 1 diabetes. Before moving on to today's session, let us have a brief look on what the topic says. Immunotherapy aims to modulate the immune system to prevent the destruction of insulin-producing cells in the pancreas, which is a hallmark of type 1 diabetes. Several studies have investigated the use of antigen-specific immunotherapy, immune checkpoint inhibitors, mesenchymal change cells, etc., to delay or prevent the onset of type 1 diabetes. We'll be learning more about the recent updates of immunotherapy to delay type 1 diabetes with Sir's wonderful inputs upon the topic that he will be pondering today. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you. Thank you for the nice introduction, and thank you for introducing the topic as well. So we understand that any form of immunotherapy done is to delay the auto-destruction of the cells. And inherently, type 1 diabetes is an autoimmune disease where cells are destroyed, the pancreatic islets are destroyed because of autoantibodies produced in the body. So to delay the destruction of the cell, so we need a lot of things which stops the cascade of the inflammatory pathways, immunoresponse, be it the T cell response, B cell response, different types of response can be targeted to reduce the inflammation and the targeted destruction of the cells. It's almost like a reverse of the cancer therapy, and this has been used in many other setups, most commonly used in the rheumatology, autoimmune disease, even many other autoimmune diseases as well. So without further delay, I go to the topic, and first I will divide the topic into three groups, three agendas, like pathophysiology, how it important to initiate the treatment like before insulin therapy, even insulin and the insulin. So burden of type 2 diabetes is the type 1 diabetes is the number of children diagnosed with autoimmune disease is increasing. There are a number of diabetic children are increasing. That's why this treatment is more important. And we read insulin is still the most important way to treat it. It can be expensive in certain situation. And there are type 1 diabetes where it is important because it is characterized with the absolute insulin deficiency, a result of pancreatic beta cell destruction. It is prone to ketosis and idiopathic in nature. Sometimes we do not get the antibody because we do not know all the antibodies which actually destroy it. So we have 3-4 antibodies most commonly tested, and most of the patients are actually antibody positive. There are genetic predisposition, we know, and associated with the secondary viral insult like the viral infection, toxic chemicals, lymphocyte infiltration, and these things also destroy the cells because of autoimmunity per se, and that is triggered by the external events like the chemicals. Some say there are cow's milk can precipitate the type 1 diabetes. Some say that or childhood viral infection can precipitate the diabetes. These are all hypotheses, and some of them are tested, some of them are not. There are immune response are characterized by the two ways, the islet cell antibodies and cell-mediated immunities as well. So it causes the B cell destruction and insulin producing cell, and insulin producing cells are actually destroyed like this. So what ends up in lack of insulin. This is how the pathogenesis of type 1 diabetes occurs, and this is the immunoresponse which people are targeting. Autoantibodies attack and destroy the pancreatic beta cell. It is through the absolute destruction of reduction of insulin secretion because the cells which are secreting insulins are destroyed. So chronic autoimmune disease, its immune system, which is actually triggered by different immunoresponse because of altered antigens sometimes, and there are molecules in the beta cells that sometimes resembles a viral protein. So if there is a viral infection, This is mimicry is called, so that body fights against the virus, and the same time body develops the immunity against the virus, and some of the viral proteins almost similar to the pancreatic beta cell proteins, and that's why the antibodies which are generated by the body's defense system also destroys the pancreatic beta cells. Why I'm saying this? Because this is the where we try to intervene to prevent the development and progression of type 1 diabetes as a autoimmune reduction response to be reduced. As I said, most of the antibodies are looked for as a GAD oxidase antibodies, anti-GAD antibody, anti-IA2 antibody, and ICA antibodies. All three are used. These are the diabetic autoimmune response. In each cell secretes a distinct things. So as I said that these are the antigens in the alpha cell, beta cells, and delta cells. So cytotoxic T cells, what happens is this effector T cell recognize the peptides from the beta cell specific proteins, and that actually kills the beta cell, not the alpha cell and delta cell. So there is a imbalance in the pancreatic milieu, that there is a fixed proportion of alpha, delta, and beta cells, which is lost if the specific targeted destruction of the beta cells by the cytotoxic T cells. Lymphocyte progenitor cells are initially generated by the host bone marrow by specific hematopoietic stem cell. This is all the basics of the immune system, how we detected since our learned since our MBBS days. And there are T cell and B cell mediated response. So T cell lymphocytes travel to thymus, where the thymus is central tolerance mechanism. That is very important. So that is where the body learns which cell not to destroy, which cell to destroy. And if that is lost, so discrimination between the self and non-self is very important, and that is lost, and that's caused the destruction of the cells of the same in their own body. CD4 regulated T cell, that is Treg cells, commonly called as this cause arrives in the blood and lymph nodes, peripheral circulatory system, and clash with their specific peptides. So if the pancreatic beta cell specific T lymphocytes and the response antigens are displayed in the MCH or HLA groups of the antigen presenting cells, that is macrophages and beta cells. So these are detected and targeted. And this T lymphocyte becomes initiated in the lymph node and ultimately migrate to the pancreatic islets and begin to demonstrate the beta cells in the antigen specific manner. So this is how the antibody response, antigen response by the T cell mediated response occurs and destruction of the beta cell occurs. But and the Treg cell characterized by the suppressive lymphocyte responsible for the peripheral immunogenicity tolerance and try to inhibit this effect. As I said, the immunotolerance stop this response. Conventional normal person like us who do not have the type 1 diabetes, the normal person, the thymus regulates the discrimination between the self and non-self, and so the auto cells, the self beta cells are not destroyed in the normal human situation. If the body unable to stop the autoimmune destruction of the pancreatic beta cells, leads up in end of in beta cell destruction, insulin deficiency, and ultimately develops the type 1 diabetes. This is the potential events sequences of type 1 diabetes. So starts with the genetic susceptibility. As I said, the genetic predisposition is documented in the different studies. Then like HLA groups and CTLR4, the tolerant receptors are very important for immunoresponse. All these mutation can precipitate the immunogenicity of the self cells, and that is maybe triggered by the virus, bacteria, nutrition, chemicals. As I said, the cow's milk sometimes precipitates the immune response to the pancreatic beta cells. Then initial CD8 cell kill the solidified by the APC. Then ultimately the B cell autoantibodies CD4 CD8 responses starts in, that is the autoantibodies develops against the insulin, and ultimately epilope spreading occurs. So it is more and more autoantibodies insulin like GAD, IA2, and ZNTB. The T8, sorry, ZNT8. These are antibodies we commonly look at. These antibodies are generated, and the CD4 and CD8 response actually destroys the insulin islet cells as well as proinsulin, and there's a different target antigens which are targeted, both CD4 and CD8. Like CD8 targets the ZNT8, IGRP, and others. And this is how the beta cell destruction starts in. So initially, as we all know, there is a honeymoon period. So beta cell destruction occurs, but we require a 50% of the beta cell is sufficient enough to not to develop the type 1 diabetes. So even if the beta cell destruction sets in quite early, we do not develop the type 1 diabetes until after the 50 to 80% of the beta cells are lost, we end up in diabetes. So goals is to maintain the glycemia. There are therapeutic options. As I said, we commonly do is still the injections with the insulin because insulin secreting cells are lost. Continuous subcutaneous insulin infusion is another option we do, and there are some and pummelintide secreted from the pancreas itself. These are also used as injective therapy outside India, not available in India. So there are needs of innovation. Why it is so? Because this is not sufficient. We are just supplying what is lost. But before but if we can stop the destruction, that could have been better. The patient can develop their own insulin without destroying the beta cells. So while insulin replacement is beneficial, as I said, it limits its innate ability to replicate the endogenous insulin function because we give the insulin peripherally and body secretes the insulin in the enteric circulation. So the utilization of the insulin is much better. Requirement of insulin is much less unless when we give the insulin from the peripheral circulation, like we give the subcutaneous insulin or IV insulins. Recent immunotherapy progresses towards the pancreatic islet-specific immune pathways, fueled the achievements of the therapies. As I said, with the learning from the other therapies like rheumatological therapies, we learned how to stop the immune response in the islet cell as well. There are different types. As I said, the insulin is a very important till now. Insulin pumps are there for the type 1, CGM is there for type 1. Surgical treatment is there, pancreatic islet cell transplantation. I'm not going in details of that because that is again an option. Even the India has a lot of work on this. Islet transplantation has been done in the PJ Chandigarh, and few of our colleagues are doing it here as well. So immunotherapies is the third option. We treat the type 1 diabetes. Surgical, just in brief, that pancreas can normalize the glucose level, and because if we transplant the islets, like renal transplant, like we go for cardiac transplant, liver transplant, we can also transplant the islets, which is lost, which can be replaced from the outside, and that can normalize the glucose level, and microvascular complication can be prevented. There are studies on it. Potential adverse is again, we require immunosuppressive therapy. Like all the transplant, we also require the immunosuppressive therapies to prevent the destruction of the transplanted cells, and that can be defective to maintain sometimes. So we try to find out not to go for a surgical way, but to stop the inflammation and immunodestruction of the beta cell itself. So type 1 to reestablish the tolerance mechanism. So that was the target. So we lost the tolerance in the thymic tolerance is lost, self and null self destruction is lost. So target is to maintain the reestablish the tolerance mechanism and eliminate the pancreatic cell specific immune response. These are all lost, and we'll can again start it later. So this is the way we stop the inflammation of primary T and B lymphocyte, which preserves the destruction of the cells and maintain the insulin throughout the life. So there are two different way of curing the type 1 diabetes, such as immunotherapies, stop the attacks on beta cell. And second is creating the insulin producing beta cells. So these are two way of looking at it. I'm not going here beta cell therapy. We are going for immunotherapy today. So targets is to disable bad overactive immune system, boost the good regulatory mechanism, that is regulatory CD cells are stimulated, and identify the risk individuals earlier so that we can detect the genetically before the development of type 1 diabetes. Because if you develop the type 1 diabetes already, by that time 50% to 80% of the beta cells are lost. So you have to detect the patient early to go for immunotherapy strategies. That is very important to remember. Possible immune-based therapies is repair the unbalanced immunotolerance, ex vivo regulatory T cell generation, Treg cells, that is regulatory cells which suppress the immune response, can be given outside. So it is possible nowadays with the advancement of technology. Then we can also consider ultimately the HLMS transplantation, which does not develop the immune response as well. Repression of the inner arm of immune system is another option. So there are many drugs are tried. This is a very difficult area to intervene. I'm not going in details of the all trial. It may take 2 hours to discuss then maybe, but altogether I'm giving a nutshell of the trials. and how the pathogenesis of the trials are considered. So, for example, therapeutic targets were the anti-CD3 antibodies. These are oxalitumab and teplizumab, which actually prevents the activation of the T cells, depletes the T effector cells, and restores the T effector Tregs ratio. So, this body immune response is mainly dependent on the T effector cell and T regulatory cells. So, normally in the type 1 diabetes or the immunodestruction, Treg cells are lost. So if you can alter the Treg race and T effector cell response, that improves the outcome. So these are the different studies. Oxalitumab, monoclonal antibodies are considered MUVAB mostly. So oxalitumab is the DEFEND 1 and DEFEND 2 trial. Teplizumab is trialed in the PORIGE and ABATE trial. These are very famous, and now teplizumab is approved by US FDA almost 1 to 2 years back in the US to prevent the trial. So it is so effective nowadays detected. So for example, the oxalitumab trial, there is no EBV in the therapy group, but there was no statistically significant difference in the area under curve of the C-peptide in the 12 months. So there is the first antibody trial maybe, but it did show some response, but not a full effective one. But teplizumab trial in the PORIGE trial that shows that at 1 year, there is no significant difference HbA1c. At years of 2, the C-peptide in the high dose groups were considerably greater than the placebo groups. The C-peptide response actually shows the survival beta cells. So beta cell survival is much more with the teplizumab compared to the control arm. This ABATE trial shows the treatment group baseline adjuncted A1 area under curve C-peptide reduced at the 2 years were considerably lower. So C-peptide response is good. Again, both the teplizumab studies in the long run. Even the rituximab trial is done. Rituximab is most commonly used for different other immunoresponse, even very commonly used in hematology. So it is based on the B cell response. It is the monoclonal anti-CD20 antibody which blocks the B cell function. Again, the antibody production is tied to lost, and HbA1c lowering at the rate of C-peptide declines, and the insulin level decreases in the response to therapy, but it is not sustainable in the rituximab trial. But it did show some response in the HbA1c and a reduction of insulin requirement in the type 1 diabetes, even after development of type 1 diabetes. The co-stimulator blockage, this is a trial CTLA4 IgG that abatacept is very commonly used in the other fields, and CTLA4 IgG1 chimeric proteins is a decoy receptor of the CD80, CD86. So decoy receptor actually use up the antigens and antibodies. So if the decoy receptor is there, it reduces the antibody level. So that is the concept of giving the decoy receptor, and this is considered a co-stimulator blockage. Stimulation and blockage is done together. There is a significant highest simulation of the C-peptide in the 2 hours and the area and the treated groups and end of the treatment and the 1 year post-treatment as well. So even after stoppage of the treatment or 1 year after treatment, there is a significant improvement has been documented. So this is co-stimulator blockage is quite promising. This is still not available, but abatacept is a very important co-receptor stimulator blockage. So it again, the tidal trial did show that significantly higher stimulated area under curve of the C-peptide, which is the response to the beta cells in the treatment group compared to the placebo, and insulin requirement is lower in the treatment group as well. Coming to the cytokine-based therapies like interleukin-2 agonists, again, very commonly used in rheumatology. Aldesleukin, that is interleukin-2 maintains the Treg population and the function. So we, as discussed before, alteration of the T effector cell and Treg cells are very important in the development of the autoimmunity. So if you can improve the Treg cells, that can suppress the T effector cells and the balance is restored and inflammatory response is less. So a dose-dependent elevation of the Treg cells has been documented with the interleukin-2 agonists, but HbA1c decrease is almost equivalent. There is certain response is documented. TNF antagonism, that is etanercept, again used in the other fields as well, but in the type 1 diabetes trial, it shows the HbA1c decreases while endogenous insulin production increases. So even if the person develops the type 1 diabetes, even after that, the insulin requirement decreases with the etanercept therapy. Interleukin-1 receptor blockage, that is anakinra, again used in rheumatology very commonly. But unfortunately, it does not see peptide response, lower the insulin requirements, though, but C response is not documented compared with the controls. Lower insulin dose is adjusted, but it is not very significant, so trials are not continued. So all these things quite important now. Coming to the interleukin receptor blockage, that is anakinra, as I've discussed, the immunomodulation and reverse relationship between the inflammation and C-peptide has been documented. Interleukin-6 therapy, tocilizumab, this extent trial is going on. So antigen-based therapy like antigen-specific therapy involve the direct targeting of the T-reg cells, which are T effector cells, which are actually destroying, and improve the T-reg cells. That is boosting of the T-reg cells is done, shown to be more prevalent in those who have a larger dose of the oral insulin. So even the oral insulin is used as a immunotolerance, that is very important way of doing the immunotolerance even in the allergy response, allergy therapy in the other fields of the medical avenues. Its immunotolerance is developed with the oral insulin trials as done to improve the immunotolerance, not as the insulin therapy for that, but it improves the immunotolerance. So Treg based cells has been again the subset of the adaptivity is transferred. Treg cells still in the circulation at the year 1, and there is no significant adverse effects, and C-peptide preservation has been documented. In the DC-based therapies in type 1 diabetes individuals who have autologous, this autologous transplantation of the disease exhibited the limited output. So these are quite complicated, but these avenues are all tried to reduce the inflammation. And main thing we should remember that T effector and Treg cell should be maintained in the normal balance as the normal human beings, not altered, which the Treg cells are reduced. So all these targets actually improves the Treg cells and reduce the T effector cell or cytotoxic T cells. Combination therapy with cyclophosphamide and the GCSF has also been tried, which used in again other immunomodulation. And this shows 32% were insulin free for 4 years, maintains the C-peptide, but increased side effects has been documented, so the trials were abandoned. T cells were actually recognized the native and foreign antigen presented by the APCs. And Treg controls the escape autoactive T cells. So Treg cells improvement is the main target here. So this is the diagrammatic way. So improves the immunotolerance is the key. Teplizumab has delayed the onset of type 1 diabetes, and both adults and children, and average 2 years in the phase 2-3 clinical trial. It is more about reducing the immunotolerance attack, and ATG, an FDA-approved drug, preserves the beta cell function and improves the immunotolerance. So teplizumab is the anti-CD3 monoclonal antibodies most successful till now. Abbott trial did show administration 2 courses of teplizumab or placebo were administered shortly after diagnosis, again after 1 year in 52 type 1 diabetes patient, and patient treated with teplizumab had 75% reduction in the decline in the C-peptide at 2 years. So that is quite a significant achievement. And decline in the C-peptide reduction means that beta cells are preserved. So this is the teplizumab treatment in the new onset type 1 diabetes. The study concluded treatment with teplizumab preserves the insulin production, reduce the exogenous insulin in the new onset diabetes. So this is the Kaplan-Meier curve of teplizumab delays the type 1 diabetes at risk on average 2 years in the recent clinical trial. So versus placebo, it reduced the development diabetes average about 2 years. Oxalitumab, again, a CD-clone antibody, it does benefit with the anti-CD3 therapeutic effects. Rituximab, as I said, is a CD20 antibody. Teplizumab is most commonly trial, as I said. So it improves the stabilize the beta cell function in antibody positive high risk individuals. So patients who are GAD antibody, anti-IL-2 antibody positives, they were treated range of around 74 to 3000 days, and hazard ratio of development of type of is around 4.45. So almost 50% reduction of risk of development of diabetes has been reduced. Almost 2 years reduction delay is documented. There are some obstruction in the immunotherapies, like insulin is long been available, so it is more convenient for us. The lack of approved immunotherapies, because all these trials are short and not so done for longer period and not effectively tried in the population in large. So we need a lot of more data and looking for the adverse effect, because immunomodulation has a risk of lot of adverse effect. If they stop the immunity, lots of cancer cell can potentially go up. So you should be very clear about no other side effects and complication develops with the immunotherapy. That should be our target. So no single therapeutic agent provides a lasting health benefit. Combination therapies are evaluated, but cautions are maintained as we have discussed in the trials. Ideal timing and dosing is still not known, but preferably early in the diabetes or before the development of diabetes by genetic predisposition or family history should be targeted to prevent the development or delay the progression of the type 1 diabetes. To summarize, autoimmune disease, particularly type 1 diabetes, holds a great promise on the autoimmune immunomodulation therapies. Currently available immuno-based therapies, options of type 1 diabetes require more evidence to support because we have limited trials. But still, one of the drug, like as I said, teplizumab is approved by FDA. In future, we may be able to use a single or multi-immunotherapy to prevent the condition as it manifests. So we can treat the disease from the beginning and treat the pathogenesis of the disease rather than supplying the insulin which is lost, which you commonly do nowadays. Progress to other understanding of the immunobiology of autoimmune disease is more requiring more understanding and more cell guiding therapies and treat them accordingly. Thank you very much. Over to the organizers. Welcome.
Thank you so much, sir. Thank you for such wonderful insights and for delivering such a passionate talk about the topic that you have shared today. So thank you so much for that. We have received few questions from the participants that I would like to put across.
Yeah, put on first.
Yeah. The first question is, why do therapies that work for other autoimmune conditions also work or maybe work in type 1 diabetes?
As I said, every autoimmune destruction is different, and targeted cells against the particular antigen is different. So, what antigen reduction, cetyl cytotoxicity can be prevented by with the rheumatological therapies, the rheumatoid arthritis, for example, may not be working well in the autoimmune destruction of the beta cells because the response generation is different, the pathways are different, the targeted antigens are different. So these things to be kept in mind. That's why so many failures, so many limited outcomes have been documented. So it is not a single way, very easy way. So the one modulator is effective in all is not that. Every modulator has the different action and different response in different diseases. It is not so simple. It yet to be explored in totality. We still not know the full actually. You get my point?
Yes, sir. Thank you so much, sir, for answering this question. We'll move to the next question and we'll take another question from one of our viewers. And the question is, are any ATIC experts offering off-label immunotherapy for people with newly diagnosed type 1 diabetes?
Till now in India, no. In outside India, US, teplizumab is approved, is used in the limited way and getting some success, but still in India, no, it is not approved by DCGI.
Thank you so much, sir, for answering this question. We'll move to the next question from one of our viewers. And the question is, could teplizumab help people already living with type 1 diabetes?
As I said, it delays the progression of the diabetes as well, but not for long. Maybe there are few trials with the more than 10 years type 1 diabetes. Most of the trials in the type 1 diabetes with the immunomodulator therapy is 1 to 2 years of detection of diabetes. So there are data on that improves the C-peptide level, requirement of insulin goes low, hypoglycemic risk goes low. But in the long-term diabetic with the type 1 diabetes, if the beta cells are already lost, I don't think you will get much benefit in this situation. That is my understanding, maybe.
Thank you so much, sir, for sharing your point of view on this question. We will take up the other question. And the question is, what are the expert thoughts around type 2 diabetes medications being used for people with type 1 diabetes? We have a part question to this as well. The question is, are drugs like Ozempic, metformin, or Jardiance helpful for people with type 1 diabetes?
As I said, type 1 diabetes is insulinopenic. But if you have other component of the disease, because some of the type 1 diabetes getting obese because of the lifestyle, then the metformin and other drugs works well. But recommendation wise, metformin is only approved sometimes, and other drugs are in the trial. Different trials are done on that, even the SCD2 inhibitor, as you are talking about. But there are limited success and not routinely recommended as for the universal guideline.
Thank you
But
so much, sir.
definitely, yeah, if the patient is obese and features suggestive of mixed diabetes, like both type 1, type 2, we can try this drug.
Thank you so much, sir, for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for their patient listening and for their ardent participation that they have shown while being here with us throughout the session. So with this, sir, we would like to conclude the session here for today. Until next time, and we would like to have your precious last comments before concluding the session.
See, immunotherapy is a very important mode of therapy nowadays. Lots of monoclonal antibodies are developed in the last 10 years and many more to come as well. So what we have to do, but we need to be vigilant because immunotherapy is a risky. So if you handle the immunity of the body, immunity requires a lot of beneficial effect as well. It prevents us from getting infection. It prevents us from getting cancer. So if you stop the immunity altogether, it can risk of infection is much more, risk of cancer is much more. So end of the day, that is not so good. So we have to balance the immune response according to the need. So that is the most difficult part we face. We can stop the immune response by many more drugs, but that balancing is the art, and that is the more difficult part, and it's in the evolving part, not very clear till now. So we need
Thank
to
you
be
so
getting
much,
more
sir.
data. Okay, bye.
Thank you so much, sir, for your valuable comments. Thank you. With this, we
So,
are concluding the session here for today. Until next time.
okay, sure. Bye.